Hello everyone, welcome to another episode of Clinical Case Discussion. In the previous video, we have seen the local examination. In the previous video, we have seen the history part and a little bit about general examination. In this video, we will be more focusing on local examination, right? So before we go into local examination, there is one thing that I couldn't complete in the last video. So here is what is called pretibial mixed edema, which is in Graves' disease. So you need to understand something. Again, I told you wherever there is edema presentation in case of Graves' disease, it is mainly because of the accumulation of something called glycosaminoglycans. So I told you this glycosaminoglycans has got a propensity of retention of water. So because of this retention of water only, there will be edema, right? So one common question they will be asking is pretibial mixed edema is of which type, either whether it is pitting or non-pitting. Please understand it is non-pitting greater than pitting. So in majority of the cases, there will be non-pitting edema. In few cases, rarely you can have even pitting edema also, right? So what is the main mechanism? Glycosaminoglycans, right? Next. So let's get into the local examination. See, basically, whenever we are examining a swelling, the basic headings that will be there is inspection, palpation, percussion, and auscultation. Please understand that all the four headings may not be applicable for all the cases. So in GOITRE, we need to see that all the four headings are applicable, and we will see one by one, right? So first one is, please understand, whenever you are examining cases like parotid and thyroid, you need to understand it's not just about that particular organ. It is also about the adjacent anatomical structures. So what is there just behind the thyroid gland? There is trachea. So you need to examine the trachea also, right? Then what is there? Lymph node levels are there in the neck, right? So whenever there is a malignancy, it can go and cause lymph node metastasis, especially papillary thyroid cancer. So that is why, in addition to the swelling per se, we also need to examine trachea and also cervical lymph nodes. So please understand, you should not forget trachea and cervical lymph nodes, right? So the first one. So the standard method of thyroid examination is that usually, in case of inspection, you will stand in front of the patient or by the side of the patient, and you will examine for all the inspectory findings. Whereas in case of short-necked individuals, it's not that easy to check for the findings, right? So in case of short necked individuals, there is a method called Pesillo's method, where you will ask the patient to keep both hands over the occiput of the patient, and you ask the patient to extend the neck. Why? So that you can visualize the thyroid swelling very neatly, so that you can appreciate the findings properly, right? So this method is called Pesillo's method. Please understand it is done only in short necked individuals, right? Next. So coming to the swelling per se, what are all the findings that we should examine for? So the first one is side. So which side of the thyroid gland is enlarged? Especially in case of solitary thyroid nodule, you need to mention which lobe of the gland has been enlarged, and number of the swellings. Then site, where exactly within the thyroid gland, and not just in the thyroid gland, there is something called thyroid region, or which is also called thyroid fossa. So, just like we have talked about parotid region or parotid zone, we have something called thyroid region. So, what are the boundaries of thyroid region? Superiorly, superior border of thyroid cartilage. Inferiorly, suprasternal notch. Then laterally, you have got bilateral internal jugular veins. Okay, so this is about sorry, boundaries of thyroid region. So next one is size. So please understand, I told you, please go and watch Introduction to Case Sheet Writing. Whenever you are mentioning the size of a swelling in inspection, you should always use the word approximately. Right? Next is shape, then extent. Please understand. So whenever we are mentioning the extent of a thyroid swelling, we should always take help of the anatomical landmarks which are nearby. What are the nearby landmarks? So you can take superior border of thyroid cartilage again, and inferiorly again suprasternal notch, And a little bit laterally, you can take superior border of clavicle. Then laterally, anterior border of sternocleidomastoid muscle. Anterior border of sternocleidomastoid muscle. Then, if it is something like only one lobe involved, and if it is a solitary thyroid nodule, you can take medially midline. So this is how you should describe the extent of the swelling, right? Next is borders, then surface. Please understand, whenever you are mentioning the surface, there are only two words that should be used in inspection. One, even, second one is uneven. Next is skin or the swelling, whether there are any scars present to rule out any recurrence. Then visible pulsations, engorged veins, redness, etc. Then, most important in thyroid swelling in inspection is upward movement of swelling with deglutition. It is the most specific point to say it is a thyroid swelling. Okay, so please understand, whenever we are checking for the borders of the swelling, if there is something like if you are not able to appreciate the lower border of the swelling properly, then only we will check there is something called Pemberton sign. So how do you check for this? You will ask the patient to raise the both upper limbs touching the both ears. If it is something like a unilateral swelling, let's say for example the patient has got right side swelling, you'll ask the patient to turn to opposite side, I mean to the same side, to the pathological side, and you will ask the patient to take deep breath. And within few minutes, the patient, in case of a non-Indian scenario, the face will become very congestion, so there will be full redness. In case of Indian patients, usually it may not be that much appreciable, so the patient will complain that he or she is having discomfort and pain. Okay, right, that's how we will check for Pemberton sign. Please understand, Pemberton sign is checked for only if there is lower border which is not clearly delineated. Okay, right, next. So coming to the movement of swelling upward with deglutition, please understand, movement of the swelling with protrusion of the tongue is mentioned only if the swelling is present in the midline in the upward aspect, not in the classical thyroid fossa. Okay, right. So the examiner will ask you, why does thyroid move up with regulation? To understand this, we need to look at the anatomy again. So please understand, thyroid is enclosed within pretracheal fascia. So this green color is nothing but thyroid capsule, which is nothing but your pretracheal fascia. So this one. So this pretracheal fascia is condensed to form something called ligament of Berry at posteromedial aspect. This ligament of Berry is attached to cricoid cartilage. Cricoid cartilage is in continuation to the thyroid cartilage with the help of something called cricothyroid muscle, or even this cricoid cartilage and the thyroid is in continuity with cricothyroid muscle. Okay, right. Next, this thyroid, and in the upward aspect you have got something called thyrohyoid. So you can see here thyrohyoid membrane. Right, now what is the connection of hyoid to the epiglottis? You can see here hyoepiglottic ligament is there. Please understand, whenever there is swallowing, this epiglottis will close like this to close the laryngeal inlet. So whenever epiglottis is being closed, this hyoid bone will move up. All the things which are in continuity will also move up. So the answer should be, whenever there is swallowing, entire tracheolaryngeal complex moves upward. That is why thyroid gland also will move up with deglutition, right? So that is the explanation we should give. Now, so there is one important question the examiner can ask you. What are the other swellings which will move up with deglutition? Other swellings which move up with deglutition, right? So you can remember with the help of mnemonic, settle. So one T is thyroid swelling, classical. Another T is thyroglossal cyst. S for subhyoid bursitis. E for enlarged pretracheal or prelaryngeal lymph node. Then L for laryngocele. Rarely you can have this. Last E is ectopic thyroid. Right, these are the swellings which will move with deglutition. Please understand, this is a mnemonic to remember the conditions, but when the examiner asks you, you need to tell in the order of most frequent ones. So first tell thyroid gland, then you can tell thyroid, thyroglobal cyst, laryngosyle, ectopic thyroid, like that. You need to go in that order. So the mnemonic is settled, right? There is another question which the examiner can ask you. So the moment you say these are all the swellings which will move up with deglutition, then how will you differentiate between laryngosyle and a thyroid swelling? So the answer would be laryngosyle will have positive cough impulse. Okay, right. Another question they can ask you is what, even though it is a thyroid swelling, when will it not move up with deglutition? So, what are the thyroid swellings which will not move up with deglutition? Which do not move with the deglutition, move up with the deglutition. Okay, so first one is very huge goiter. Second one is radial thyroiditis. Very hard it will be, that is why. Then malignancy with skin infiltration or strap muscle infiltration. Then non-malignant condition which will not move with is retrosternal goiter. Retrosternal goiter with intrathoracic impaction. So in case of huge goiter, there is no place for the swelling to move up. So that is why there will not be any movement up with deglutition. So these are the two important questions the examiner will ask you regarding movement up with the deglutition. Okay, right. Next. So after the swelling process is over, we are moving to the second one, that is nothing but trachea. You need to, we are just in inspection. So you ask the patient to swallow and observe for the position of trachea. Then the examiner can ask you what is trial sign. Please understand, whatever side you have got goiter, that side there will be sternocleidomastoid muscle prominence will be there. You can appreciate here in the picture. And underlying explanation will be there is a membrane between sternocleidomastoid muscle and trachea. Whenever there is huge goiter, this membrane will get relaxed. That is why that side sternocleidomastoid muscle will get more prominent. That is called trial sign, right? Next. So whenever you have got visible cervical lymph nodes, you need to mention which level of cervical lymph nodes are enlarged, right? Right. Moving to palpation, in addition to whatever we have examined in inspection, one important additional thing that will come here is carotid artery pulse. We will see how we will need to check and all. So first one is swelling per se. Please understand there are certain named methods in palpation also. So the standard method of examining the thyroid is that you should stand behind the patient and keep your hands at the thyroid fossa of the patient, and you should examine with your fingers, right? Next. Coming to the swelling per se, no matter wherever you are examining any swelling in the body, the first two universal points will be localized temperature and local tenderness. Where can you expect that? So one is if there is a huge malignant goiter, or it can be something like a inflammatory swellings, right? Next. So site, number, size, shape, extent, same as in inspection we need to mention with the help of landmarks. One important point you need to understand here is that when mentioning the size, you should remove the word approximately. So you are measuring the swelling with your tape. So vertical dimension first, then horizontal dimension. Next, borders you need to palpate with your hand and check whether they are well defined, regular or not. Then surface, you have got two or three important types of surfaces. So one is something like a smooth surface. Where can you get it? Somewhere like something like a solitary thyroid nodule or even diffuse goiter. Next is nodular. In case of something like a multinodular goiter or even very rarely strian. Then boscillated. Again, boscillated you will see in MNG. Right? Next. Skin on the swelling. Then very important, upward movement of the swelling with deglutition. How will you check it in palpation means you need to hold the swelling, then you will ask the patient to swallow. Then you can appreciate the upward movement of the swelling with your hand, right? Next. Then I told you in introduction to case sheet, whenever you are examining a swelling, there are three most important points which are exclusively examined in palpation. So you can remember with the help of a mnemonic CPM. So C for consistency, P for plane of the swelling, M for mobility. So there is at the level of consistency, the examiner can ask you one important question: what is thyroid paradox? So please understand the answer consisting of two parts. First one is, even though it is a cystic swelling inside, but when you are examining, it will feel as a firm one. So cystic appears to be firm. Why? Because of the tense capsule. That is nothing but pretracheal fascia. Second part of the answer would be, even though it is a malignancy, but center of the malignancy, in the long run, it will undergo ischemic necrosis. So it will be something like a cystic degeneration. That is why, even though it is hard or something like a malignant originally, the center of the swelling may feel as soft one. So that is called paradox. Paradox means it's a false one. So the thyroid paradox is, even though it is a cystic swelling inside, but clinically it will be palpable as a firm one. Even though it is a malignancy, it will be soft in the center because of the cystic degeneration, right? That is called thyroid paradox. Now coming to plane of the swelling, I'll explain that in next slide. So next one is mobility, right? So please understand, whenever you are talking about plane of the swelling, so if it is a malignancy, first one is classical skin pinchability. You need to pinch the skin or the swelling and see whether it is possible or not. Skin pinchability. If there is, you are not able to palpate the, like, pinch the skin or the swelling separately, it means that skin is infiltrated. So next one is deep fascia. So how will you know whether the swelling is present superficial to the deep fascia or deep to the deep fascia? Very simple. Ask the patient to extend the neck. So that will stretch the deep cervical fascia. Now you need to observe one thing, whether the goiter is becoming or the swelling becomes more prominent or less prominent. If it becomes more prominent, whenever you have got this kind of a finding, it means that swelling is superficial to the fascia. Superficial to the fascia. Whereas if it becomes less prominent, it means the swelling is present deep to deep fascia. Okay, right. This is the interpretation. Now, the examiner can ask you, how do you know if it is present little bit like deep to the sternocleidomastoid or superficial to sternocleidomastoid? To understand this, you need to check whether the goiter or the thyroid swelling is unilateral or bilateral. Means whether single lobe is involved or both lobes are involved. If it is something like single lobe involved, you need to check. Let's say, for example, the patient has got right side thyroid lobe enlarged or thyroid lobe swelling. You want to check whether it is present beneath the right side sternocleidomastoid or not. Then you need to ask the patient to turn the face to opposite side. Meanwhile, you will be keeping your hand on the cheek of the patient and you will ask the patient to push it against resistance. Then the sternocleidomastoid muscle will become prominent. Again, you will check for this, what is happening to the swelling. If it is becoming more prominent, if it is present superficial to the sternocleidomastoid. If it is becoming less prominent, it is present deep to the sternocleidomastoid muscle. So this is something called sternocleidomastoid contraction test. That is ipsilateral. Whereas if it is a both lobes of the thyroid are enlarged, then you will go for something called chin pressure test. Chin pressure test. What do you mean by that? You will sit in front of the patient and you will apply the thumb over the chin of the patient and you will ask the patient to press it against resistance. Then you will check, like, both the sternocleidomastoids will be becoming more prominent. Now, they will be contracting. Now you will check whether the swelling is becoming more prominent or less prominent. Again, the interpretation will be same, right? So this is one important point regarding plane of the swelling. Another important point regarding mobility. So please understand, whenever we are checking for the mobility, it is always vertical mobility. You should never check horizontal, because if you try to hold the swelling and move it horizontally, the entire tracheolaryngeal complex will move up. It will move. That is why horizontal mobility should not be checked. Only vertical mobility should be checked. How will you check for the mobility? You'll stand on the right side of the patient. You will keep your index finger over the superior border of thyroid cartilage or at the superior pole of the thyroid swelling. Then with your right index, you will gently push the lower border of the swelling gently. If the swelling goes and touches your left index finger, it means that it has got vertical mobility. That's how you will check for the mobility of the swelling. Never ever check for horizontal mobility. Only vertical mobility should be checked, right? Why? Entire tracheolaryngeal complex will move in horizontal direction, right? That is the importance of plane of the swelling and mobility, right? Coming to trachea, how will you check for the position of trachea in palpation means there is something called three finger method. So as you can see here in the picture, you will keep index finger and middle finger on both sternoclavicular joints and you will keep your middle finger in the middle. You will ask the patient to swallow and you will gently draw the middle finger inferiorly so that you can appreciate the trachea position. Now coming to carotid artery pulse. Please understand this is very important. You should always check for the bilateral carotid artery pulsations. So how will you check? As you can see here in the picture, first step is ask the patient to turn opposite side so that it will relax the omohyoid space. Turn to opposite side. Then where you need to check the pulse superior at the level of superior border of thyroid cartilage. Common carotid artery will be bifurcating into internal carotid and external carotid. So that is why this is happening at the level of superior border of thyroid cartilage. Just 0.5 centimeter below, just below superior border of thyroid cartilage. That's where you will check for the pulse. Just below superior border of thyroid cartilage, right? And one important point you should please understand, whenever you are checking pulse, it will be checked against a bony landmark. So what is the bony landmark here means Chesagnax tubercle. Chesagnax tubercle. What do you mean by this Chesagnax tubercle? It is nothing but prominent transverse process of C6 cervical vertebra. So prominent transverse process of C6 cervical vertebra. That is called Chesagnax tubercle. So you will be pressing this artery against this bony landmark so that you can appreciate for the pulse. Okay. So these are the precautions you should check. Please understand, Berry sign is nothing but absence of common carotid artery pulse. So you should understand that we are checking for the common carotid artery pulse. Okay. So absent common carotid artery or absent carotid pulse is called Berry sign. Why is there Berry sign happening? Because of the infiltration of the carotid sheath. Please understand this is the mechanism. So whenever there is a malignancy, it will go and infiltrate the carotid sheath and also this common carotid artery that will lead to absence of common carotid artery pulse. That is called Berry sign. So these are the important points regarding carotid artery pulsation, right? Next. So coming to cervical lymph nodes, you need to go behind and stand behind the patient and you will appreciate the levels of different levels of cervical lymph nodes. I have already explained this in case of parotid case swelling, where there are 7 levels of cervical lymph nodes, and you need to check for the 6 levels of cervical lymph nodes because seventh one is nothing but anterior mediastinal. You cannot appreciate that usually in clinical examination. You need to go for imaging, right? Next, whenever you have got enlarged lymph node, these are the basic headings under which you should describe the enlarged lymph node. Number which level of the cervical lymph nodes is enlarged, size, shape, borders, and whether it is tender or not, and whether it is something like a firm or hard. Because usually firm will be something like a reactive lymphadenopathy. Hard is usually seen in meds, lymph node meds, and whether they are separate or matted, right? Next, coming to percussion, please understand percussion is not mandatory in goiter. So when is percussion done in case of a goiter? Only if the inferior border of the goiter is not made out well. So where will you percuss? Over the manubrium sterni, direct percussion. Why? To rule out retrosternal extension. This is how clinically you can appreciate this retrosternal extension of the goiter. Normally you will be having little bit resonant tone. If there is the retrosternal extension, it will become dull. Okay, right. Now coming to auscultation, I have explained this point when we discussed anatomy. So at the superior pole of the swelling, you will be examining for the bruit with the help of bell of stethoscope. Okay, right. Why only superior pole? Why not inferior pole? Please go and watch the first video on the thyroid swelling, where I have explained the reasons why we need to check at the superior pole of the thyroid swelling. Right. Coming to systemic examination. So first one is musculoskeletal, where you are trying to check for the spinal tenderness, pulsatile metastasis to skull. Where will you come across this pulsatile metastasis? Follicular malignancy. So PFAML, papillary follicular anaplastic medullary thyroid cancer lymphoma. So in the follicular carcinoma, you will get usually pulsatile metastasis. Now, why should you check for cardiovascular system? Whether there is any secondary thyroid toxicosis. And in respiratory system, you will check to see if there are any adventitious sounds, etc., etc. And in abdomen, you will be trying to check whether there is any splenomegaly or hepatomegaly. Because in case of very rarely in lymphoma of the thyroid, you can get other lymphoid organs in the abdomen which are enlarged. Right? I told you in hypothyroidism there will be sluggish reflexes, and also there will be proximal myopathy. Okay, that's what you need to check for. Then oral cavity must, you should check whether there is any lingual thyroid swelling. Okay, just for completion sake. Now coming to provisional diagnosis, I told you in provisional diagnosis there are three important compartments or components. So first one is anatomical diagnosis. Clinically, we have only three things: whether it is solitary thyroid nodule, if it is a solitary thyroid nodule, which lobe of the thyroid is enlarged or involved, then multinodular goiter, then diffuse goiter, right? The only three terms clinically. Then functional diagnosis, whether the patient is in euthyroid based on only history and examination findings. Whether the patient is in hyperthyroidism or hypo, then probably it could be a benign or malignant condition. Okay, so let me give you an example. My provisional diagnosis is a solitary thyroid nodule in right lobe of the thyroid, clinically euthyroid, probably a benign condition. That's how you should describe the provisional diagnosis of the patient, right? So, thank you.